All right, we've got a great interview for you guys today. It's George Halvorson, and he is an interesting cat, as you're about to see. He's the former CEO of Kaiser Permanente, a giant healthcare group, obviously, and he is now the president and CEO of the Institute for Intergroup Understanding. He's written 9 books. The last one is 3 Key Years, and talking about the first 3 years of a kid's life and how important that is. That's a really interesting topic. He's also written Ending Racial, Ethnic, and Cultural Disparities in American Healthcare, and Healthcare Will Not Reform Itself. You have a funny line in one of your speeches about how you were now working on world peace because it's actually easier than healthcare reform, right?
Yes, exactly.
So very interested in your thoughts on healthcare reform, because obviously you spent a lifetime working on it. And I should also say that George has won just about every award there is, and was chair of so many organizations that I literally can't list them all for you guys. But and then in 2015 he received the Impact Visionary Award from Ad Age. And I like this, you were in the Scandinavian Hall of Fame. Okay, that's fun, that's fun. I received the Golden Turk Award once, but I haven't quite made the Turkish American Hall of Fame yet. So I'm not quite where you are, George. And obviously I can go on and on. Named number 6 on Modern Healthcare's annual 100 most influential people in healthcare back in 2012. Okay, so then George, given this rich history, it's hard to know where to start, but healthcare is such a giant issue here. And I think right now, especially with push for Medicare for all, I think let's start there. And then I want to talk to you about your work on fighting racism and this developmental issue that you focus on, that you've got amazing stats on. Okay, so first of all, you ran Kaiser Permanente for a long time, and Kaiser is a little different than the rest of the industry. I don't know much about it. I'm very curious. How is it different? Everybody always tells me about it, but I've got the former CEO here, so let me get it from the horse's mouth.
The rest of healthcare in this country is siloed. It is basically set up as separate non-systems. Individual doctors practice separately from other doctors. Hospitals are not connected to other hospitals. I mean, the country is really heavily siloed, and Kaiser Permanente functions as a team, functions as a vertically integrated team. So the doctors, the hospitals, the labs, pharmacies, x-rays are all part of a totally integrated team of caregivers.
So let me try to understand this. So in the rest of the country, there's doctors and hospitals floating around, and they sometimes work together, but they don't have to. It's Kaiser, you've got them all lined up. So if a doctor works with Kaiser Permanente, he's going to work with Kaiser Permanente hospitals and other providers. So what's the advantage of that?
Huge advantage of that. You get much better care. The patients end up with a higher quality of care, better care outcomes, better care far better care for diabetics, 40% lower strokes than the rest of the country, half as many asthma attacks for kids. Because when you focus on preventing the asthma attack, the rest of healthcare makes its money by having an asthma attack, and they treat the crisis, and then the kid goes into the hospital. The hospital makes a lot of money on the crisis, and each piece sub-optimizes and benefits from the crisis. Kaiser Permanente is the exact opposite. The members pay a fixed amount before all care, and inside Kaiser Permanente, the very best financial model is to prevent the asthma crisis. So Kaiser has half as many asthma crises. Kaiser Permanente has the lowest death rate from HIV. It has the lowest death rate from stroke. And basically, because it's a vertically integrated care system where the caregivers are focused on the patient and focused on best practices and not focused on billing. And the rest of healthcare really is organized around opportunities to bill. So that's a big difference.
Yeah, that is a huge difference. So let's talk broader now. So what's your thoughts on universal healthcare?
We're the only industrialized country in the world that doesn't cover every citizen. That's ridiculous. We spend more money than any other country by a multiple of 2, and we don't provide care to everyone. We have more than enough money in the system to do that. We just need to organize ourselves appropriately to do it. And we should be able to cover everyone and spend less money than we're spending now.
So I believe we spend on average $4,500 more than the second closest country, or their average of developed countries, some monstrously high number.
Monstrously, exactly.
That's right. So where does that $4,500 go?
Well, it goes into waste and efficiency and very, very high incomes for
who?
For caregivers. And so if you look at Canada, spends about 12% of its GDP on care. We spend 17%. Okay, so if you took, but Canada sets the fee schedule at the government level, so they set every fee. If we took the Canadian system and delivered every piece of care we deliver today, every hospitalization, every test, every scan, every surgery, every single thing, but just priced it at Canadian levels, our cost of care would go from 17% down to 13%.
So that's savings that are so high that it's hard to count, right?
Hard to count.
Yeah.
If you want to, Canada also uses a single payer system, so it takes out the insurance cost, but the insurance cost will take you from 17 to 16. But using the Canadian fee schedule takes you down to 13.
So why do we pay so much? Why can't we negotiate better? I mean, I thought we had a guy in office who's wrote an Art of the Deal.
Yeah, we don't prices are not negotiated in healthcare very much at all, and they're not negotiated in terms of a package of care. So we buy all the care by the piece. And when you buy care by the piece, then you end up with piecework care. And you actually end up with an incentive to deliver worse care. I'll give you an example that in this country, roughly 10% of patients end up with a pressure ulcer in most hospitals.
What percentage?
About 10.
Oh, wow.
Okay, the good hospitals are about 5.
That's really high.
Yeah, the good hospitals are about 5. Kaiser Permanente was at 5 a few years ago and decided to systematically improve that, so it took us from 5 to 4 to 3 to 2 to 1. So Kaiser Permanente only has 1% of the patients that have pressure ulcers in the hospitals, and the other hospitals are still 5 to 10, much higher. But those hospitals make $40,000 on every pressure ulcer patient. So if you're going to take $40,000 per patient out for 5% of your patients, what's the incentive to get that right? Kaiser Permanente is prepaid, so KP has far safer hospitals than the rest of the world because the incentive is to be safe and not to have an infection.
So how could the government fix that? Like if they wanted to fix that today, we know that it's, they're incentivized to charge more because they're going to make more. So how do we end that incentive structure?
Well, one of my books basically is called "Do Not Let Healthcare Bankrupt America," and I explain in that book how the government can reprice the way it buy care by the package, not by the piece, and get much better prices and much better outcomes than they do now. We could easily, the government could go there, but the government has to go there. The problem is there's a huge lobbying pressure from all of those care sites that are doing really well financially. And because if the computer industry was generating 17% of the GDP of the country, we would say that's a huge winner economically. Healthcare, we say it's not a winner, but functionally it is.
Some people are winning. Some people are making a lot of money, and they've got all the incentive in the world to lobby to keep the system as it is. So who are the ones that have the highest incentive? Is it the drug companies? Is it the insurance companies? Is it the hospitals?
Drug companies in this country charge 2, 3, and 4 times more per prescription than they charge any place else in the world. So
it's just highway robbery.
Yeah. So we for a Lipitor prescription in this country, we might pay 140, and in France it would be 40.
Yeah.
In Britain it'd be 30. I mean, if you look at the drug prices in the rest of the world, it is a fraction of the U.S. So right now, 14% of our healthcare dollar goes to drugs, If we paid European prices, that 14% would drop to 7%. Right?
Well, so that would save the country billions upon billions of dollars. It would save citizens billions of dollars, but it would cost the drug companies those same billions of dollars.
Right, it's a zero-sum game, and so it's not a zero-sum game. If you stop paying that to the drug companies profits would go down, and the consequence of that we don't know. None of them would go out of business. They would all continue to function. Their shareholders would have a brief period of time when their stock prices changed. But at the end of that brief period of time, we would have a 7% savings in the cost of care for America.
Yeah.
What else can you do to get 7% savings?
It's gigantic. Yeah. But if you had universal health care, would that put the insurance companies out of business?
No. Every other country, one of the myths, it's fascinating. One of the myths is that Europe uses single payer systems. They don't. Only Canada uses a single payer system. The rest of Europe uses health plans. They use competing health plans. So if you're in Switzerland or if you're in the Netherlands, there's not one single person in that country that has government coverage. They all belong to health plans. They all join exchanges. I was the chair of the International Federation of Health Plans for 10 years. I chaired the group that represented all those countries. I know all those health plans. They exist. They're always amused that the US seems to think they don't exist. But that is the model. Germany actually invented health plans. Bismarck, when he was trying to unify Germany, wanted to have health coverage for everyone. Didn't want the government to do it. So he invented sickness funds, and they compete with each other. So Germany is full of competing health plans, like Aetna, WellPoint, Cigna, Blue Cross. Germany's full of sickness funds.
So how do they keep the cost down, and what does it mean to, like, how do they implement universal coverage? Because if you're an insurance company, it's normal.
Well, they require everyone to buy coverage.
Okay.
So
that's like a mandate.
It's a mandate. It's a total, absolute, clear mandate. If you're a Swiss citizen and you move from one town, one address to another, one of the first things you have to fill in on your moving form is which health plan you've picked for the new site, because they take that money out of your paycheck. I mean, they are really fanatical. They have a mandate in all those countries. So they don't have universal, they don't have national insurance. They have national mandate.
Right, and by the way, we have a mandate here too. It's just on car insurance. If you own a car, you must have car insurance.
Exactly.
That's a mandate. That's all it is.
Same. Okay. Yeah.
So and they have a mandate so that they don't die.
Yeah.
So that's a pretty, it's an understandable mandate, right?
And they get better prices because everyone's in the insurance pool. So the insurance isn't just the outliers. And they also, in every country, set maximum costs, maximum prices for pieces of care.
So they will say, okay, if you're going to get a CAT scan here, Germany, for example, says the CAT scan is going to be, name it, $50, $500, whatever it is.
Right.
And that is what it is. So here in America, they would immediately go, whoa, that sounds like communism to me. How could the government set prices? What's your answer to that?
The answer is CAT scans in this country. The prices on a CAT scan range from about $50 to about $5,000. Same scan, same site, same care delivery. All of those prices are artificial. They're all made up. They're all market based on what a given payer will pay, and they have no relationship to the basic cost of providing the care. In Europe, they say the CAT scan is going to be worth $200, would be a typical. And all of the care sites that have CAT scanners charge $200. In the US, there's this vast range. But the US sites could get by just fine with the European price.
You know what, it's funny, it's almost ironically communist the way we do it. Take as much as you need and pay as much as you have. Right, so if you got the $5,000, we'll charge you the $5,000.
Right.
Right. So there's definitely significant irony in that.
Well, coronary bypass surgery in the US, over $100,000 per procedure. No place else in the world charges more than $20,000. Many countries charge $10,000, and they have outcomes that are as good or better than ours for $10,000.
So how about the doctors? You know, they say the argument by the right wing is, we have the best doctors in the world because we can pay them more, et cetera. So does the government set the wages for doctors in a country like Germany? And if not, how do you handle that cost?
Germany, France, all of those countries have better, faster access to primary care than we do. So they all have an infrastructure of primary care because they pay primary care doctors more relative to specialists. We pay specialists 3 and 4 times as much as we pay primary care. So we have a shortage of pediatricians, we have a shortage of family practitioners, and the European countries pay about the same for those specialties, so they have enough surgeons and they have many more primary care doctors. So you start out with better outcomes. You also end up with a faster access to some kinds of specialty care. And the European health outcomes are as good or better than ours. And we're actually about 30th in the country on life expectancy. In the world, I mean, not in the country. We're about 30th in the world. So many countries are ahead of us, the systems that we're talking about, because if you have immediate access to care, in Switzerland, 60-70% of the people have same-day access to primary care. In the U.S., 20-30%. Yeah, so that's a myth that those countries ration. They don't.
Yeah, so it's funny they say that. Just randomly today, I was trying to get a doctor's appointment. Okay, but not having anything to do with this interview, obviously, and they gave me one 2 months from now.
If you're a Kaiser Permanente member, you would have it tomorrow.
Okay.
Kaiser Permanente, immediate appointments. You get in immediately, and you get in with a caregiver who is going to have your complete medical record, all the information about you electronically, and will know what you need. And follow-up visit, at least half the time, can be done electronically because it's more convenient for you to do it electronically.
Yeah. So look, we're not doing an ad for Kaiser here. I don't know if I don't know if you still got stock in it. I got no horse in that race.
No.
But I get the logic of it, because if you're focused on keeping costs low, you want primary care right away. You don't want that guy to wait around for 2 months.
Exactly.
Because the quicker you do prevention, the less costs you're going to have later. Same thing in the European model, which is that if you pay your primary care physicians more, you're going to have more preventative care and less costs down the road. Whereas we emphasize paying the costs down the road, which are far higher, right? And so we shouldn't be surprised that our bills are higher.
Yeah, so we have huge numbers of hospital infections. Hospital infection rate, the #1 cause of death in American hospitals is sepsis. It actually kills more people than strokes or heart attacks or any other condition. Sepsis is the #1 cause of death, and we can prevent sepsis. So again, Kaiser Permanente hospitals, some other systems, the Catholic hospitals in California have done a really good job on sepsis. And so the sepsis death rate is much lower. But the rest of the country, the #1, and sepsis is extremely expensive.
Right. So I understand all that. And so when they say, by the way, oh, rationing, you gotta wait. We gotta wait in our system. I gotta wait 2 months before I can do a checkup. It's unbelievable.
No, our system has very long waits compared to Europe. You would not have that wait if you were Swiss. If you're Dutch, you would not have that wait. Great Britain has waits. Great Britain does a really good job on primary care. So every citizen has a primary care doctor, and the doctors work with them. But Britain does actually ration specialty care. So they have a shortage of specialists and subspecialists in some areas of the country.
Yeah. So
that's where you get the urban myth that Europe makes its money by rationing, or it saves its healthcare expenses by rationing. But Britain's an outlier.
Yeah. No, that's one of the things that drives me crazy, not just about healthcare, but all the issues, is why don't we look at what works throughout the world?
Exactly.
Why is that so difficult?
Yeah.
Right?
No.
And so it sounds like the British system has some problems, so let's not use the British system. Let's use the system that gives you the best results for the least amount of money. Not that complicated.
Switzerland.
Yeah, Switzerland, you know.
And you know what Switzerland uses?
What's that?
Obamacare.
Okay, it's got to be a little bit more nuanced than that.
But exchanges. Everyone gets to pick from an exchange, and you have a subsidized premium, and people actually get their care from that system, and they get data from the system. It is a functional clone of the exchange part of Obamacare.
Interesting. So, and you supported universal health care coverage before Obama was in office, and then you supported the Affordable Care Act when Obama pushed that through. So, one more thing on that, I
would have pushed more strongly for the European model, where it was a universal mandate. I would have, if we could get every American covered, we could do it for a lot less money. And what we've got is too many people who, even with Obamacare, did not take coverage.
Yeah, and so how about Medicare for all?
As a Medicare for all, the reason that Medicare, two things. The reason that Medicare costs a lot less than the rest of care is fees. They actually use the European model for Medicare. The government sets the fees.
Right.
So that model would actually work well for some people. And Medicare right now, most of the Medicare people join Medicare Advantage plans. And if they join a Medicare Advantage plan, what you get is a health plan who has agreed to, for a fixed amount of money every month, to provide full coverage and care to you. Those plans do a really good job of managing care for diabetics, so they have fewer diabetic complications, they have fewer strokes. The Medicare Advantage plans are doing well, and I think the government is going to be promoting Medicare Advantage plans as part of the Medicare agenda.
Yeah, so Medicare gives you a certain minimum amount of coverage. You can do Medicare Advantage. And by the way, that doesn't prevent anybody from offering more insurance on top, more private insurance on top.
Right, you can buy supplemental coverage on top of your standard Medicare.
Right, so if we were to do, you can call it the Sanders plan, but it's been around for a while and a lot of other people support it. But say, hey, look, if Medicare works for people above the age of 65, why not age of 60 or 55? Hey, wait, why not just Medicare for all? Is that a workable plan? Is there something wrong with it? I don't know, I genuinely ask.
Medicare all by itself has really poor care quality. There's no tracking, there's no care improvement. The care for diabetics inside Medicare is typically extremely inconsistent. The caregivers have no mechanism or incentive to coordinate with each other. And so you often get some really inadequate care in the Medicare model because it's not structured to provide team care. The part of Medicare that does provide team care, you end up with much better care and better outcomes.
So, but that's not a structural problem in the concept of Medicare for all.
That's my point.
You could just fix that.
You can fix that, exactly. You can fix that. You could actually fix that part of Medicare. And if you actually made it, and again, it would look then a lot like the Swiss model, because Medicare would then be, everyone would have it, and you could then choose your health plan in the Medicare Advantage plan. And there is a real advantage having competing health plans because they figure out how to improve your service, how to improve your health status. They figure out how to make you active and work on weight issues. And so it's good to have a health plan in the equation rather than just siloed independent doctors that aren't connected to anything. Yeah. So if you use a Medicare model that also takes advantage of best practices in team care.
Yeah. Then great. Okay. All right. Good deal. So out of curiosity, if you had something like Medicare for all, how much of an issue would that be for a company like Kaiser Permanente? Are there shareholders now going, George, what are you doing? What are you doing?
Well, KP is about a $60 billion company. Okay, it is totally prepaid. So it's 95% prepaid. There's some cash coming in that's independent payment, but it's almost entirely prepaid. In a Medicare for all environment, if you have the kinds of choices I was talking about, KP would do wonderfully. KP has 1 million people now on a Medicare Advantage plan. They already take a prepayment from the government for Medicare members, for over 1 million of them, and they do just fine. In fact, KP, Medicare rated 550 health plans in the country, and they 1 to 5 stars, and 11 health plans in the country got 5 stars, top level. 8 of them were KP plans.
I was going to guess at least one of them was KP. You're the 8 out of 11.
8 out of 11, and one of the other was my old Minnesota plan. So that model, vertically integrated plans, do really well on quality, service, and outcomes. But the patients in that model have a choice. And you can take a look at how many stars your plan has, and you can, and all of the plans have a strong incentive to increase their performance against the STAR program. And the fee-for-service Medicare doesn't have that. Fee-for-service Medicare, you just go to a provider and they may or may not have any kind of care coordination of any kind.
Okay, I lied.
Most don't.
I have one more question about healthcare. I can't stop asking. Okay, and then we are going to go on to the racism issue and the developmental issue because they're super interesting. Okay, so what if you did? You said, okay, everybody's got an option of going into Medicare now if they want to. So the government's not mandating that you all do Medicare, but we're giving you that option. So if you're 45 years old, if you want, you can just do Medicare. Is that possible? Does that make any sense?
You mean as another alternative option in the total market?
Yeah.
You know, I don't know where healthcare reform is going to end up, but you can design a model where people can voluntarily get to both Medicaid and Medicare at a certain point, and Medicaid has some real advantages. Medicaid done well can be really good care, and Medicare done in team care can be really good care. So if individual consumers could choose those paths based on their income status and their proximity to the care teams, that model could work just fine. Because it would be systematic care, we'd be tracking the outcomes and you'd be monitoring the performance and you'd be giving consumers information that they need to make decisions. Right now, consumers have no information to use to make decisions about care.
Yeah, you know, I dream of a democracy where we have these rational discussions, and I bet if you had 10 smart, rational guys, you'd come up with the right plan at the end of the day. But the problem is the lobbyists, and they come in and they're not going to allow you to do democracy. They're not going to let you do a rational plan.
Well, I was just I was just at a meeting of 20 caregiving organizations, multi-specialty group practices, the big national clinics that do that kind of work, talking about what they would perceive for a perfect future. And what they would love to see would be a system where they could enroll people, they could get a fixed amount of money to do it, KP-like model, and then they could design their care delivery around the patient and not around the billing. And right now, things like cutting the infection rate costs so much money that a lot of them aren't doing it. But if the minute there's a financial reward, everyone will flip and care will get better.
Yeah.
And then the hospitals would, I guess my point is, those big systems would love it. They would rather be there. They would rather, their leaders would rather have that model because they'd like to sit down with the flow of money and figure out the best thing to do for the patient than what they're doing now, which is figure out how can I get 3 more CT scans per 10 patients.
The incentive structure here is insane. Okay, so now let's go over to, you talk about racism and discrimination, et cetera, in the context of healthcare. What is that? What are you referring to?
Well, one of my books is Ending Ethnic Racial Disparity in Healthcare. And what I talk about are the facts that in this country, if you're African American male and you go into a hospital with a heart attack, you're half as likely to get a painkiller. There's a whole series of things identified in the book where there are significant disparities and differences in care delivery based on race and ethnicity. And we need to take that out. Kaiser Permanente, we identified by each patient, because we have electronic medical records, so we have all the information about every patient all the time. And part of the information is race and ethnicity. So then we track care delivery. So in San Diego, I could tell you what the difference was between Hispanic population, African American population, pick any of the other populations, relative to prostate cancer death rate, detection rate, the diagnosis rate. I mean, all of those types of things are available from KP, and I read about that in the book. And once we identified that there were significant disparities by group, and even in KP, where it's a vertically integrated system of the same doctors, we discovered that we had some significant differences. That the death rate for HIV was significantly different for Black patients than for white patients, for example. And so what we did was we re-engineered the care, focused the care, got the care to be really good for everybody, but then got rid of the differences and did some coaching and counseling and channeling. And so now for HIV, the death rate is the lowest in the country for all Black and white and every other group. You can do that in an organized system with right incentives, and if you don't have an organized system, you can't do any of that stuff.
So look, of course, and George, I don't know your politics, but I mean, when you're having rational discussion, so I'm assuming you're progressive, but I don't know. Anyway, so because the right wing will say, no, you're making it racial. Why are you bringing race into healthcare? But the data shows across the country, right, that right. And is it? And let me ask you: is it on an issue by issue that African Americans, Latinos are getting worse care, or is it for all of the healthcare issues? Do you see what I'm saying? Are they getting worse care on HIV specifically, or is it across the board?
Well, what I say in my book is there tend to be differences in care delivery that have links to race and ethnicity, and you need to track those, and you need to change them where there are differences. And it's entirely possible once you identify them to make changes and improve care for everyone. And so the model, the goal needs to have complete data about all the patients, and with that complete data, focus on where there are opportunities. Prostate cancer for Hispanic patients, for example, tends to have a very low number of people willing to have the exam.
Okay.
So what did we do? We did some coaching, we did some teaching, we did some prompting, and now the death rate for that cancer is as low in that population as it is in the other populations.
So that's interesting. You see, that's if I've got it right, that's not racism, but it is racial, right? There's a racial disparity. Well, it's not the doctor driving it in that case; it's sometimes the patients that are driving it.
And what I say in that book is that there's a couple B's involved. That bias is definitely part of the issue. Behavior is part of the issue. And biology is part of the issue. So some groups are far more susceptible to become diabetic, far more susceptible to diabetes. So you have to recognize that and focus on that. Then you got behavioral issues. People, if you're overweight, if you're inactive, you're far more likely to have chronic conditions. And then you've got pure bias. And bias basically says that if two people both have Alzheimer's, you treat them differently. And we need to deal with all three, and as we identified in the book was that they're co-equal. So the biological issues, you are far, far, far more likely to end up with certain kinds of breast cancer if you're an African American woman. Well, that has nothing to do with bias. That's totally. But what you have to do is you have to know that data so you can help that particular population of women have the exams at an earlier age.
So it seems like the answer is education, and I think that it is relatively easy on two fronts, but not necessarily easy on the third front. So what I mean by that is, if you know that your biology predisposes you to one thing more, you might want to get that checked more. So if you are educated about that issue, you go, okay, hey, if I'm an African American woman, I really got to make sure that I check for this kind of breast cancer, so I'm going to go in early and I'm going to do that exam. Check, problem solved, as long as you have brought that education to all the different groups and all their different issues, right? So on the behavior issue, similar, hey, if you don't do the prostate cancer check, you're more likely to get prostate cancer, right? And then that's your call.
You're more likely to die of it. You're not more likely to get it. You're more likely to die of it because it gets detected.
Because we caught it late.
Yeah.
Right. Got it. But the bias issue, that's where it gets political. So if you said, okay, now I'm going to train all the doctors in the country that unwittingly, I'll say mostly unwittingly, that you might be treating patients a little differently, and look at the data and the results that that's showing, it's having a really large outcome difference, right? Well, you're going to get a lot of pushback, right? Like, wait, are you calling me racist?
You know what? I don't think there's that much pushback. If it's data-based, if you actually pull up the database and say this set of treatments varies by group in these ways, and you show that's true based on data, then my experience has been people are then willing to change behavior based on the data. If you just say, I think you're biased and prejudiced.
They're going to shut off, right?
Yeah, and don't support that with anything. Then people don't have any sense of, oh, what can I do with that data? And you're insulting me, and go away. But if I sit down and say, your Hispanic patients are not getting this test, so you need to coach them more and encourage them more, and we need to track how well your patients are getting that. We actually saw those lines change significantly in just a couple of years.
Yeah, and luckily doctors are obviously highly educated by definition.
And science-based. Doctors like to be scientists. There's a sense of, and doctors all like to be number one. All the people got into medical school by being number one in high school, number one in college. I mean, they're used to being at the top of the performance level, and so they like that. So if you put out, I mean, Kaiser Permanente, and I talked about the infection rates in the hospitals. We actually got hospitals down. The year I left, the year I retired a couple years ago, we had 7 hospitals that did not have one single pressure ulcer in a year. Now that's the rest of the country is 5 to 10%. We did not have one single because everybody, once they got going down that path, got really competitive about it.
Oh, right. And we're going to bring it down more.
We're going to bring it down in the other ones. We're going to be the best. And a couple of nurses who had patients that got pressure ulcers, we actually had to provide counseling for because they felt so bad that they had let their team down and their patient down. It wasn't their fault, but because some are just going to happen.
Yeah.
But
that's good, though.
It changes the culture.
Ironically, they get a stress ulcer.
Yeah. Exactly.
So from dreading, no, seriously. So I get that you're saying Kaiser's doing it. Is the rest of the country having this kind of education, whether it's with the groups themselves or the doctors, addressing it on those 3 points, or are we generally not having that conversation?
All over the country, the Affordable Care Act created ACOs, Accountable Care Organizations, and the goal of the Accountable Care Organization is to be a Kaiser clone. So that was built into the law. It was deliberate. It was intentional. And the ACOs are having inconsistent success. Some of them are doing well and providing better care. Some of them are not doing as well, and they're on a learning curve and they have to get better at it. But the ACO model is a really good idea, and we need to get better at it and spread it, because Accountable Care Organization basically is what it sounds. It's organized and it's accountable and it's delivering care, and the financial model rewards that, and so we need more of that. And then the other thing we need to do is we need to do a much better job with computer support for care. And we need all of the patient data centered on the patient. What we have now is all the data centered on the care site. So if you have allergies and you have cancer and you have asthma, that's 3 different databases for you, and they don't even talk to each other. They don't connect with each other. And so what we need is the data, unless you're at Mayo or KP or a couple programs like that, and then it connects. But what we need is that kind of data connection for all patients. So if you go into doctor for your asthma, they know you've got cancer.
Yep.
And
that's just
we need to follow it.
Obviously.
It's super logical, but there is resistance. There has been some resistance to connecting the data, but we need to overcome that and do it because the benefits are massive.
So now I'm back into healthcare politics. So the Republicans in the House passed their ACHA, where they repealed Obamacare and have their proposal. What do you make of it?
Well, they had promised so many times to repeal Obamacare, they had to pass something. I mean, they literally, and so they had to get enough votes from all the constituencies. So they moved the components of that bill around in various ways to generate votes. And it really wasn't, there was no one sitting back there saying, what's optimal care going to look like for the country, or what's the best financing model? And so it was sort of ideological and political, and not built around somebody who had a great vision for what optimal care should look like. So that is not a bill based on optimal care delivery. That's a bill based on how do we get, what is the number of votes? How do we get to 218 votes or whatever? Okay. Now that they got those, they passed it. Pressure's off them. Now they've thrown it over to the Senate. Now the Senate has to figure out something. And they've got a totally different set of pressures and a different set of realities, and the Senate's got some major challenges. And one of the major challenges is one of the very best, most brilliant and wonderful things that Obamacare did was expand Medicaid.
Mm-hmm.
We're the only country in the world that does not provide coverage to its low-income people.
Mm-hmm.
And Medicaid expansion did that. That, to me, if there's nothing else in the bill that happened that's important, that's beautiful. Because there are so many poor people in America, millions and millions of poor people, who have a doctor. Whose kid gets sick and they can take them in. I mean, that's miraculous. It's a wonderful thing. So the expansion of Medicaid is a wonderful, wonderful thing. And they put incentives in. Some states didn't accept the expansion of Medicaid because states got to do it. But many states did, and many of the states that did have Republican governors and Republican senators, and those people love it, and the hospitals in those states love it because it's paying for their hospital care for other people who otherwise would have no funding at all. And so there's a lot of people that love it. So the Republican bill basically puts all that at jeopardy, the House bill.
Yeah, they cut $800 billion from Medicaid.
They cut it from Medicaid, yeah, which is a criminal and horrible thing to do. If you are asking what my leaning is on that, criminal and horrible is a leaning. And so what we need to do, though, and what's going to happen in the House or the Senate, though, is they can't cut that Medicaid in those states in the same way because those senators will not get reelected because they will be hated by all the people who lose their coverage. And so that makes it much, much, much harder for the Senate to do that type of thing. So if the Senate does their bill and they send it back to the House and they haven't cut the Medicaid, then they're going to have a hard time getting it passed in the House, but the Senate can't do a bill that cuts it. So then is there a set of horror stories where in conference committee they kind of do the worst of all worlds that has happened in the history of American politics, but it's not what we should bet on.
Is it conceivable that the House version of that bill could be better than Obamacare?
No.
No. Okay.
No, it doesn't have care provision. It takes coverage away from Medicaid populations. It undermines it changes the subsidies for low-income people. And subsidizes high-income people, but literally a 60-year-old person can end up paying 4 times as much for their insurance next year if that bill passes.
4 times as much.
Yeah.
It's a disaster.
Yeah.
I got news for Republicans. 60-year-olds vote.
The 60-year-olds vote. No, the impact, which is why AARP totally, completely opposes the bill. American Hospital Association totally opposes it. AMA totally opposes it. Every form of organized care delivery is opposed to that bill because of those reasons, because they don't want the older people not to be able to have coverage. Yep. So I don't think it's a serious, as designed, a serious player. But the thing that we do need to focus, though, on is in this country, we need to help our kids. And what we have right now is the number one predictor for who's going to be in prison at age 18 is the number of words in their vocabulary in kindergarten.
So, super interesting. So that leads to your book, 3 Key Areas.
It does, actually.
Yeah. So, and now, because it all ties in. Look, that's going to tie into your healthcare. It's good. Let's put that. Nope, you got stuck in the box there. There you go.
There we go.
Okay.
Good book.
Because it leads to the issues of healthcare, and there's also a racial component, and et cetera. So it ties all of our conversation. That's why I saved it to the end. So. So why is that? So talk about that amazing stat you just said. Why the number of words in their vocabulary is the greatest indicator?
Well, the number one predictor for who's going to be in prison is based on the fact that the children who drop out of high school, the students who drop out of high school, overwhelmingly go to jail. And so 60% of the African American males in this country who dropped out of high school, who are in their 30s, are in jail today.
Too amazing to believe. That's literally unbelievable.
Yeah, the total number of African American males in jail today in this country exceeds the number of African American males who were enslaved at the beginning of the Civil War.
Yeah,
so
amazing.
you go back, I mean, it's a number issue, but you go back and look at the number of people in jail, but it's 60% who drop out of school. It's 10% of the ones who didn't drop out of school, but you can predict with 80% accuracy by age 3 whether or not the kids are going to drop out of school. And that's because all the brain development happens in the first 3 years of life. The neurons connect in the first 3 years of life. That's when the brain gets strong. And the kids who have someone talking to them, playing with them, reading to them, interacting with them, in the first 3 years build billions and billions of neuron connections. And they last for life. So that all the kids who have that exposure, get their brain exercise in those years, do well. And the kids who don't have that happen, the kids who are isolated, ignored, don't have anyone talking to them, by the time they get to 4, can't catch up because the brain chemistry changes at 4 and the brain prunes itself. It actually prunes out unused connections and cells. And so what happens is kindergarten, pre-kindergarten is too late. At age 4, the kids, so you can do all kinds of things to help the kids be happier. You can do things to help them be wiser, but you can't make them significantly smarter after 3.
Okay, hold, because you've now put me in a panic, because my kids are 6 and 4. Okay, so, it's too late. I should have read your book earlier.
But right, but you have read and talked to your kids. Number 1, you have.
So let's talk about what you need to do in those first 3 years for optimal return, if you will.
Let's go down. Yeah, let's go down a couple paths, because one is what you do for kids in that time frame, and then what do you do if you've missed that opportunity, and what do you need to do later? But what you need to do in the first years is you need to talk to the child, you need to read to the child, interact with the child, play with the child, and you need to, Harvard Center for the Developing Child has done some magnificent work on what they call volley and return, where the child says something and you react to it and you have a volley and return with the child. That actually builds brain cells by the billions. It's incredible. The little brains light up, the kids they beam, they're happy, the brain just explodes when, literally, you get explosions of connectivity in the brain of the children who are getting happy connections with their mother, their father, their grandmother, whatever, in the family. So you get that explosion happening. And the kids who are isolated, the brain doesn't connect, that part of the brain doesn't link up. Those billions of connections do not happen. And you get to age 4, and it's too late. Those kids have tiny vocabularies, they cannot do well in school, they never learn to read, and they drop out of school.
So there's a couple of different elements here. One is the vocabulary then allows them to do better in school and et cetera. But is there also a social element to this, that if you don't build those neurons that connect you to other human beings, that you lack empathy and become a Republican?
Well, let me actually let me go back and add one other thing, because that's first 3 years, but there's also the first 3 months. And there's epigenetic science now that shows us that the brain actually structures itself differently. So in the first 3 months, when the brain epigenetic factors are at play, if a child is hungry and is fed, and if a child is stressed and is comforted, the brain wires itself in one direction. But if the child is hungry and not fed, stressed and not comforted, the brain literally wires itself differently. And you have a different brain at 100 days. And the children who end up with the negative wiring end up with presumptive negativity as a syndrome, so they assume the world is negative. Any interaction comes to them, they respond to it as though it's a negative interaction. And the kids who get the other response think the world is positive, and so they're looking forward to new experiences and they're welcoming the world. And so you get 2 very different sets of behaviors. And Dr. Beatrice Beebe at Columbia did some magnificent work, and she can videotape a mother-child interaction at 100 days and predict with 90% accuracy which kids are going to be in trouble at 1 year, 3 years, and 5 years.
Wow.
At 100 days.
So
back to your point earlier, though, so what she says is, don't give up on the kid at that point, intervene. So she's all about, let's assess every kid at 100 days. identify the ones that are in problematic status, and then provide some kind of adult intervention, either help with the parent or get another parent or get a grandparent or get an outside. But she believes in interventions because you can still save the kids at 100 days. 100 days isn't hopeless, but 100 days is inevitable if you don't intervene.
So, quick side question: Ferber method, where you make have the kid cry themselves to sleep, is that deeply problematic given what you're saying?
That's not optimal. No.
Oh, that's interesting.
Yeah. When the kid, it depends how old the kid is. If the kid is 4, you're fine.
Yeah.
But no, at the beginning of the process, you want the kid. The kid who is stressed needs to be comforted at that point to get the brain wiring going in the right direction. So you need to comfort the child, you need to feed the child, you need to interact with the child. And the children can tell differences in languages at like 6 hours old. I mean, the research is stunning. Yes, they can tell, when they're just hours old, the brain actually reacts differently if they hear a language that wasn't the one they heard in utero.
So in the first 6 months, to a normal parent, the kid appears to be a blob. Okay, but what you're saying is the exact opposite.
Exact opposite. The kid is exploding. The neurons are connecting like crazy. They're connected by the billions.
So you should read to your kids in the first 100 days, even way more so than when you read to them when they could actually understand it.
Yes, you should be interacting with the children in loving, supportive ways immediately, and books is part of that. But talking is huge. Just simply talking to the child, interacting.
Boy, do I talk.
Yeah, no, well, talking.
Thank God for that.
The kids with talking parents end up much smarter. The kids whose parents talk to them, yes. And I assume you got smart kids, but if you talk to
we don't know yet, jury's out.
Yeah,
but the only person I know who talks more than me is my wife, so we got that covered.
You got it covered. But that's what you need. And what's going on now is that we don't tell that to mothers. So mothers have a child, take it home, and do not know that they're supposed to talk to the child, and don't know that talking is magical and creates all kinds of connections. The mothers who learn that immediately change behavior, and they love it, because all mothers love their children. They really want their children to do well. And so you really want the children to do well. So the mothers basically change behavior when they get the coaching, but if they don't get the coaching, they can't change behavior because they don't have the knowledge. And it's been extremely disrespectful. We have not taught that to low-income parents because we've been saying that challenging lives, we don't want to put that burden on. And I think that is stunningly disrespectful and dysfunctional. And we need to help every single parent understand that, because when you understand it, you can make a difference. And dads are really, really important. Right now, most fathers feel that they had no value at all. And we now know from multiple studies that the interaction, there's a trusting interaction with a father figure that's actually really good for the child's emotional development, really good for emotional stability in a child, and is good for the intellectual growth as well. And so the fathers who just talk to the kid, they don't even have to read to the kid. The fathers who talk to the kid in interactive, loving, supportive ways, the kids are brighter, happier, healthier kids.
Okay, so last couple of things here. So if you got a kid that's under the age of 3, especially in the first 100 days, so talk to them, interact with them, make sure they're comforted. Yeah. Anything else? Or is that's the top 3?
You feed them. You want to make sure they're well fed. I mean,
right.
But no, it's literally talk, read, sing. And then when you get to a little older, 18 months to, you start basic counting. Counting is really good. How many apples is this? Just basic, not advanced math, but arithmetic is really, really good. And kids' brains get much stronger if you do little, just simple.
I wish I read your book earlier. Okay. Okay. Yeah. So at what age are they hopeless? Seriously.
Yeah.
I know nothing's hopeless. I know that. But at what point have their brains really basically developed and we're done with it, and then you really got to manage what you got?
It's harder. You can still make improvements after age 4. It's just much harder. You can, if you work with a 4-year-old child who is way behind, you can still, because there's still connectivity happening, you can make a difference in that child, and so you can take them up to a better level of performance than they would have if they didn't have the interaction. And there's a lot to be said for emotional stability, for caring interactions with children, even if they're slow intellectually, it's wonderful to have that caring, positive interaction. So it helps give the kid a better life, even if they're not going to be a PhD. And so you end up with there's never a point where we should give up on the kids, ever, never. And we can help kids, but on something like kindergarten and pre-kindergarten, we want great kindergartens and great pre-kindergarten, but that's only going to help the kids who really got the right start in the first years.
Yep. So, George, you've done your job because you've sufficiently panicked me about this issue, and so there's a couple of issues where I think like the lead in the air in the 1970s, and now we have the lead in the water. We know how toxic lead is. You got to get it out. That's an absolute priority, no question about it, right? That now this has now jumped up to near to the top of my list.
Absolutely.
If we know all the developments happening in the first 3 years in the brain, for God's sake, everybody should focus on the first 3 years.
Yeah.
Right.
Yeah.
So are there a lot of groups other than your group?
No.
No?
Not enough. No.
So is that what the Institute for Intergroup Understanding is doing?
Well, that's working on issues of the ethnic conflict and whatever.
Yeah.
But a big part of that is we're not going to have peaceful societies with African American communities if we are putting everyone in jail. We got to go upstream in that process, and we got to change the trajectory to jail. And we need to do understanding. And one of my books is Art of Peace, and it's a balanced art of war. So art of war is win-lose, art of peace is win-win, art of war is deceit, deception, art of peace is trust, honesty, candor, transparency. And so what I do is I talk about in that book, how do we get intergroup understanding going, and how do we have interactions with people that make sense and that create trust and create a sense of us? Because we instinctively divide the world into us and them. And if somebody is an us, we're protective, supportive, forgiving. If somebody's a them, we're territorial, antagonistic, distrustful. We do horrible things to them, we enslave them, we firebomb them, we do evil things to them, and we feel no guilt, no conscience. That's our hardwiring.
Damn, George, you got this thing figured out. You're absolutely right. What I explained on the show recently was that it's not that conservatives are less empathetic. I kid around about that, right? And it's that their definition of us is smaller.
Yes, it's a different definition of us.
Yes.
And so within that definition, ethical, caring, kind, gentle, all of
great
the right
to their
stuff.
Family, great inside the church, etc. But you go outside the clan.
Then you are a non-person, and anything can be done to those people, and not only can anything be done to the people, but you feel right damaging them.
Right, you're righteous in that cause.
You are righteous in that cause. You feel good damaging them, which is why we have to extend and broaden the sense of us. We have to do that.
All right, George Halvorson, I could now see why you're in the Scandinavian Hall of Fame. Everybody, look, if you got kids or you're gonna have kids, even if you don't, but especially if you're going to 3 key years. Look, I don't do this in every interview, okay? I wish I read this earlier. But thank you for coming and share this information. Super appreciated, both on healthcare, race, and developmental issues. Thank you so much, George.
Thank you.
Young Turks members get to watch every single interview live as it happens. TYTnetwork.com/join.